Hey, everybody, Karen Anderson here with Aortic for this week's Week in Review, which is being shown to you today on Tuesday. That's because we just celebrated Memorial Day and I am away. Yeah, still away. But super excited to at least get this to you, even though it's being recorded. I do look forward to seeing you live next week. So before we get started, I need you guys to do me a favor. Click like, click subscribe, and click the little bell so you're notified every time we go live, because we have lots of really great live events, including one tonight, which we're going to talk about in a few moments. And you don't want to miss these. You don't want to have to try really hard to remember these live events. So let the computer do the work for you. But right now, we're going to talk about some of the posts we put up last week. And this really gives people an opportunity typically to interact with me, to put their questions and thoughts. You can still utilize chats and put your information and your thoughts in there. I'll be more than happy to write back as Karen Anderson and give you a little thank you for giving that shout out. But typically, we love having people come on live here and chat with me. And I guess we're just going to go ahead and take it away and get started. Now, this is a little different than we normally do things. Normally, I'm using my mouse. Things are happening on a second computer screen, my normal microphone. So when you see me reaching, it's because my mouse died. I'm not in the normal house with the computer, and I have to click my computer screen. So we're going to make it work. All right, so let's get started, because last week we had Medical Monday, and this was written by Cy, one of our med students, and we are talking about aortic valve disease, which, as we know, there is aortic valve, or actually Heart Valve Disease Awareness Month, and that happens earlier in the year. But we really want to talk about how important the aortic valve is and what a vital part of the heart it is. For those of you that are new or you don't really realize it because maybe there's nothing wrong with your valve, it's important to know, because things, as we know in this world, can change on a dime. But the aortic valve, I guess in a nutshell, what it does is it regulates blood flow from the left ventricle, which you know is the lower chamber, because the upper chambers of the heart are the atrium. So it regulates the blood flow from the left ventricle into the aorta. And that valve, that swinging door, is your aortic valve. And it opens and closes with every heartbeat, ensuring that the blood moves in the right direction and in one direction only. And that is heading out to the rest of the body via the aorta. And now, while most people have a valve with 3 leaflets, and I'm going to show you that in a second, that is what people would be born with. That's considered a normal heart valve. Some are actually born with 2. You will never just all of a sudden one day your 3 leaflets turns into 2. It's called a congenital heart defect, which means you're born with something other than 3 leaflets. So it doesn't have to be just 2. It could be 1, which would be an unocusp. It could be 4. But most common abnormality would be bi, which is 2. It would be bicuspid aortic valve. And this small difference of going from 3 leaflets down to 2 really can have some major implications for the heart and the aorta and its overall health. So let's take a look at this. So here you see that you show the valve with the 3 leaflets, right? And that is what a normal tricuspid valve looks like. And it's located where this arrow is, right where the aorta is. It's located, as we mentioned, in the left ventricle, the lower area of the heart, and it kind of is that gatekeeper to the aorta. This is what an abnormal heart valve looks like with just 2 leaflets. That's called a bicuspid aortic valve. See, and it has 2 because one of them ended up getting fused. You can see that it meant to have 3, but something happened during internal growth, during fetal development, and it turned into 2. This is not something that you necessarily even know about from the moment you're born. It usually shows up on a scan in an incidental finding. So 95% of people, the aortic valve actually has those 3 leaflets, which are made up of this thin, flexible connective tissue. This tri-leaflet structure allows the valve to open fully and close tightly, which is minimizing wear and ensuring efficient blood flow. Tri-leaflet valves are generally very durable and remain functional for many, many, many years. This isn't something that wears out in everybody, but it can. But it will last for many years, typically without any issues, unless affected by aging. Because think how many times that valve opens and closes in a lifetime. So with aging and use, it can start to develop a little issue. Or if you have any other type of health condition that can also, I guess, overuse the valve and cause it to kind of have some wear and tear. Normal valves, as we talked about, allow full blood flow, as shown by this top graphic. This is what the valve, that's a cross section of the heart on the left, and then you see what it would look like looking into the valve. It's kind of triangular in shape, and those three leaflets come together. On the right, you can see how it's closed. The three leaflets close tightly and securely. Now, bicuspid valves, they may actually restrict the blood flow because the flaps might be missing or could be fused together. So the one on the left shows the aortic valve with only two flaps, bicuspid. And you can see that there's different ways where the flaps can be fused together. So you could have them opening and closing, and I guess it doesn't matter. Is it the left? Is it the right? Is it the bottom? I guess it depends on the direction in which you're looking into the valve. Roughly 1 to 2% of the population is born with a bicuspid valve, which is typically known as a BAV. So when you're in the world of Facebook and you listen to all these acronyms and abbreviations, BAV stands for bicuspid aortic valve. Again, only two leaflets. And the reason I keep repeating this is not only because it's in the post, but because you start hearing this and become really familiar with it. This congenital, nothing that you can do to yourself can cause this. Remember, this congenital variation can function normally, but for a time, um, but then it often leads to these complications. So, with fewer leaflets handling the same workload, the valve is prone to stress and deterioration. So, over time, BAV can cause aortic stenosis, which is narrowing of the valve. It can also cause aortic regurgitation, just like that word sounds, it's leakage. So it allows backflow into the left ventricle. And there's a whole world of hurt that can happen with that over time. That blood flow that goes backwards can actually enlarge the left ventricle. And enlargement of the heart, that can become a little problematic and sticky, right? It also can create changes in the aortic wall, and that is very common. And that means having an increased risk for an aneurysm because if it's stenosis, you're going to end up with a lot more pressure because it builds up. And if it's regurgitation, that also can cause a weakening or an aneurysm, which could also lead to dissections. Why your specific valve type matters. So, knowing whether you have a trileaflet or a bicuspid valve is really crucial for early detection and management. And many people with BAV are asymptomatic. And the funny thing is when they're diagnosed with bicuspid valve, all of a sudden they have all these symptoms. But typically it's going to be asymptomatic. And that could last for years. So having regular imaging like an echocardiogram, which will show the actual blood flow, or an MRI, a cardiac MRI, and what's interesting in this case, a CT scan isn't the golden standard when it comes to looking at valves and their function and blood flow. That is going to be a specific test called a cardiac MRI, which shows blood flow like an echo, but it's just overall enhanced with the MRI imaging. So either of those two tests that were mentioned would work. They can help identify issues before they become serious. And ongoing monitoring by a cardiologist is often recommended for people with bicuspid valve, even if you don't have any symptoms. And symptoms can range from shortness of breath. So maybe somebody is just having shortness of breath for a while. They can't understand why. Maybe they're having some retention of fluid, right? They're just, things are just feeling a little different. And they go in and then they decide to do an echo and they find out they have a bicuspid valve. That's amazing. Like these things, finding out these things are really beneficial because now you can be monitored properly and hopefully we avoid an aneurysm forming or a dissection from happening. Look, even though the aortic valve is only the size of a coin, so we're not talking something that's gigantic. The aortic valve opens and closes more than 100,000 times a day. It's important. It's really important. So whether it's trileaflet or it's bicuspid, understanding your valve anatomy can really empower you to take control over your heart health, which is super important. So thanks so much for joining us in understanding our Medical Monday and more specifically Cy. Wonderful post. Thank you for explaining this for us. And I hope this really just helps and educates you more about your aortic valve health. That's a lot. It's a mouthful, right? Mouthful, Josh. It's weird not to be able to take calls from people too, but I find it You know how I like having that one-way conversation because then I get to talk and monopolize. But I love this post. I think it's super important to understand because a lot of people, their valves are spared and they don't have any issues if they have a dissection or they're diagnosed with an aneurysm. But then sometimes your valves become faulty over time. And so it's kind of good to know. So you're not as scared if you're diagnosed with something in the future.
What I find
Medical.
most
Yeah.
interesting about the bicuspid valve thing is how often
Hmm.
people find out about it later in life.
Right.
Hmm.
Very common. It's pretty common. I don't think it's as common as men with prostate cancer. From what I read, a lot, so many men will die having had prostate cancer and they never ever knew. That's how common it is. And it's so low grade. Um, and then they stop testing for whatever reason at a certain age, and you just don't know. And I think a lot of people, unless it becomes overwhelmingly symptomatic, may never know that they have a valve issue, you
Still,
know?
you would think that we would have some kind of imaging,
Standardized testing,
right?
right?
Imaging to say, oh, by the way, this could be a thing.
So weird that we don't. We
Hmm.
image so many other things for well-known issues, and this could become deadly. So
Mm.
that means another avenue of anybody who wants to help become a lobbyist with aortic go because I don't have the time, the bandwidth, but wouldn't that be awesome to really start looking for some ways to make change? Instead of just men who are overweight and smokers over the age of 65 getting their abdominal aorta scanned, which is not even widely accepted for women yet, these simple scans they didn't cost so much money, right? Just none of it makes any sense to me. Whole other conversation, right? For another day. But that's Monday. All right. Gosh, here we go. We're moving on to Tuesday, which is great because Tuesday moves from the valve into the aortic arch. See what we're doing? We like even skipped over the ascending and we're moving right into the arch. It looks like they're tearing apart, finishing tearing up the aorta and discussing its different anatomy and function. So can't wait to see what we talk about in June. So this is from Kiana, and she wants to talk about looking at the aorta as a highway. It's funny how all these different doctors learn. Is it a garden hose? Is it the super highway? I can usually guess the age of the teacher by what they use as their reference point. So let's look at it today as a highway system, stemming out of the heart, right? Extending down to the legs and exiting at different levels of the body to make sure the blood is getting to all the organs. So if you kept up with the May blogs, and you can always go back and read those, um, you've already known that uh, you've driven through the heart. We went through all the sections of the heart in May. We went through the aortic valve, the aortic root, the ascending aorta, and now we're kind of ready to enter that candy cane shape part, which is called the aortic arch. So we refer to our previous blogs in the image below to reorient you to where we are now in the arch in relationship to the entire highway system. So if we take a look at this picture here, um, which is weird for me. I don't have my cursor to point. But if you see on the right, you'll see aortic root and you'll see aortic valve. We just talked about that on Monday. At some point, we have discussed the ascending aorta, but now we're into the arch, which means I think we're going to talk about the three main vessels that come off of the arch. And you can see then it goes down into the descending aorta and all those branches, renal and there's celiac. There's so many branches off of the abdominal into the iliacs at the bottom. Okay, so when we enter the aortic arch, I feel like we're on this mystical journey. There's three different exits. Yay, we're going to talk about. There's three different exits that you can actually take if you don't want to continue through the aorta. And these are called the three great vessels. It's the brachiocephalic artery, the left common carotid artery, and the left subclavian artery. So the first exit, which is that brachiocephalic, I hope I'm pronouncing it right, artery, it splits into two branches. So let's go back to that. See that one all the way on the left? It goes up and it branches out. So why is it doing that? Where is it taking us? So the right of that is called the subclavian artery, which supplies blood to the right arm. Cut right there, okay? So our first exit, which is the brachiocephalic artery, and God knows I'm not a physician, I hope I'm pronouncing that right, it actually splits into two branches. Let's take a look at that. See that all the way to the left, which is actually your right of your body, if you think about how your aorta sits. So it has two branches. And what does that do? So the first one is the right subclavian artery, which supplies blood to your right arm, and the right common carotid artery, which travels up the right side of your neck to bring the blood to the brain. So that first exit off the highway is kind of really important. The next stop is the left common carotid artery, and that extends up the left side of your neck to supply blood to your brain. Also, a very important exit. Our third great vessel coming off of the arch, and the last major exit point is the left subclavian artery, which brings blood to your left arm. All of these vessels, as we know, carry freshly oxygenated blood from the heart to support the function of different parts of the body. And here's a great visual. So you had that first one, the brachiocephalic artery, that then branches itself again into the right subclavian and the right common carotid. Then the middle exit, the second exit, is that left common carotid artery, and the third exit is the left subclavian artery. That's it. That's our great brief review of the aortic arch, because those are the most important parts to hit when it comes to the arch. You've got these other important vessels. So when a dissection occurs in the arch, you're typically going to want to make sure that we haven't had any deterioration or any impact to any of those three branches off. Because if you did, then they're going to be making you a replacement that includes part of those branches as well. So next week, we are going to talk about the descending aorta and the abdominal aorta. So again, if you have any questions about any of this, another great visual of things branching off here, you can always shoot us a question. We'll make sure to have one of our clinical advisors answer that for you. And that is your topic Tuesday. Good stuff, right? Good stuff. I find it all extremely fascinating. I love knowing how my body works, and I love challenging myself with saying exciting words. So that's our topic Tuesday.
Excellent work.
Thank you. Oh gosh, here we go. More big words as we move into part 4 of reviewing our Genetics 101. So let's talk about, in the last article, we were discussing Loeys-Dietz syndrome. And because these connective tissue disorders are a really important part of the genetic component that goes on with aortic disease. Loeys-Dietz syndrome is a lesser known but aggressive connective tissue disorder that raises the risks for aneurysms and dissections beyond the aorta. That's its biggest problem, is it's not going to stay contained to just the aorta. It can literally find dissections happening anywhere. So this week, which was last week, we continued this deep dive into genetic conditions, and we took this closer look at something called Ehlers-Danlos syndrome, or otherwise known as EDS. That is actually a group of disorders that affect connective tissues in different ways, and some are more dangerous than others. Okay, so while not all forms of EDS carry risks for aortic complications, one subtype, and it's called VEDS, or vascular Ehlers-Danlos syndrome, that really demands special attention, because what happens is you can have fragile skin to life-threatening arterial ruptures. You know, VEDS it needs to be distinguished from other types of EDS, because if you know you have VEDS, it could literally be a lifesaver. So let's unpack the types, the signs, the genetics, and all of the care strategies that come with VEDS, because awareness isn't optional. It's vital, right? In the last article we did, we delved into Loeys-Dietz syndrome, which is a connective tissue disorder that is likely more common than previously thought, and which has a significant risk for the development of aneurysms and dissections, not only in the aorta, but in other arteries as well. And so as we continue to journey, not only in the aorta specifically, but just in the world of general genetic connective tissue syndromes, it's time to turn our attention to Ehlers-Danlos syndrome. So this group of related connective tissue disorders brings its own unique challenges and nuances. Just as LDS and Marfan syndromes, EDS is the awareness is crucial. It's critical, particularly for survivors, families, and caregivers dealing with or suspecting that they might have an aortic dissection. As always, don't hesitate to email us here at info@aorticope.org or Ryan Rodimer, our genetic educator, at ryan@myaorticjourney.com if you have any questions. Okay. Overview of EDS subtypes. EDS is just not one condition. And that's the crazy part when it comes to genetics. What we have been finding over these weeks is that you can have EDS, right? Or Loeys-Dietz or Marfan. But now there's all these different subtypes. And so with these subtypes come different symptoms and different ways of diagnosing and probably different treatment options, right? So EDS is actually a collection of disorders, each with its own specific traits and symptoms and causes. So this is crazy if you are diagnosed with EDS. There's so many different things to think about. But understanding the subtypes can help us better manage and navigate the challenges that they present. So we're going to focus on the vascular type, the VEDS. But let's start by discussing a couple others briefly. And I don't even think I remembered that there were some beyond VEDS, right? So this is going to be interesting. So the classic type of EDS, as the name suggests, is often what people think when they hear EDS. And that's going to be marked by let's see if I can pronounce this, hyperextensible. Oh, I got it right. Hyperextensible skin, meaning skin that can stretch more than usual, and skin fragility. God, I can remember I had a neighbor across the street. We thought he was stretched. Like they used to have action figures like this, which is so terrible. Now that I think about it, we had action figures where they could stretch their skin in their arms. Oh God, we were just making action figures of people with EDS. Oh my Lord. And he would come over and just pull his skin in front of me. Blew my mind. But here it is now that I know years later, he had a medical condition. It also includes widespread joint hypermobility. So you're talking about pulling that thumb all the way back, that kind of stuff, right? And atrophic, tomato, I'm not sure. That word, scarring, which basically means thin, depressed scars and abnormal wound healing. So the genetics of classic EDS are really fascinating. It's usually inherited in an autosomal dominant fashion, which means you only need one copy of the altered gene from one parent to be affected. So genetic testing plays a crucial role in determining and classifying classic EDS, identifying specific mutations in the COL5A1 or COL5A2 genes. As for managing classic EDS, it often involves multidisciplinary approach. We talked about this before. That would be having a team beyond just a cardiologist and a surgeon. It could include physical therapy, cardiac rehab, orthopedic specialists, ophthalmologists. It can include multidisciplinary people, okay, just as the word says. So here, it could include physical therapy, pain management, and surgery for severe joint instability. Although surgery, that is a difficult decision when you have EDS, and should really be performed by a surgeon that's familiar with EDS and its potential complications and difficulties in healing. So classic EDS is not thought to be a major contributor to aortic disease. Hypermobility types of EDS is another prevalent subtype, and its main features are generalized joint hypermobility, instability, and frequent joint dislocations, mildly hyperextendable skin, and delayed wound healing. It's also associated with conditions like POTS, postural orthostatic tachycardia syndrome. And the reason I can say this word is because I have been tested for POTS. It is not a pleasant test. I don't see, in my case, I've got little bits of little things, right? Okay. She could have POTS. She shows like 4 or 5 things of Marfan's, but nobody's been able to put it all together. POTS is not a pleasant thing to have to live with, even if you have it mildly. But it's also associated with irritable bowel syndrome. I get a check mark in that column as well. Mast cell activation disorder, autoimmune conditions, migraines, another 2 check marks for me, right? But I don't have everything, and I didn't test positive. So it's like I'm in that limbo land, like many of you. However, look, it's essential to note that there's likely not an increased risk for aortic dissection in hypermobility EDS, although some individuals may have mitral valve prolapse or mildly enlarged but typically stable aortic dilation. So the genetics of hypermobility EDS is still not really fully understood. So it makes it a hot topic in the research world. And consequently, management options are tailored to the individual's specific symptoms and may involve a team of providers from physical therapists to neurologists. Now, when it comes to vascular EDS or VEDS, this is the most serious form of EDS. And it really does, as we mentioned, deserve special attention due to its associated risk of arterial dissection and organ rupture. Yes, I said organ rupture. It is especially relevant to this community, and we encourage everybody to kind of learn and understand its nuances. So, individuals with VEDS, they typically have thin skin, translucent skin almost, which can often give the appearance of this delicate, like almost fragile constitution. The transparency of the skin often makes the underlying veins particularly visible, especially across the chest and the abdomen. Bruising is another common occurrence in people that have VEDS, often occurring spontaneously or with minimal trauma. However, the most concerning aspect of VEDS is the significant risk of arterial, intestinal, or uterine rupture. This is horrible. I don't know why I didn't remember this. This is very scary to read this. I mean, this is severe life-threatening complications, and it can happen without warning, and often might be the first sign that you actually have this disease in some of the undiagnosed individuals. It's amazing. Another first common symptom is spontaneous pneumothorax. Wow, I got myself all crazy. Pneumothorax, and if you remember, that's a common symptom in Marfan syndrome too. So there's a little bit of this overlap, right? So let's review. Spontaneous pneumothorax is when air escapes the lung and gets caught between the lung and the chest wall, and it can be very painful. So genetics, the role of COL3A1. When it comes to VEDS, the spotlight falls on that particular gene. And this gene is responsible for providing instructions to make a component of a type 3 collagen. Collagen is a key protein that provides structure and strength to the connective tissues throughout the body. But in VEDS, mutations in the COL3A1 gene disrupt the production of type 3 collagen. And so that results in the formation of frail and faulty variant. This abnormal collagen, it's unable to provide the necessary structural support to the blood vessels and the organs, which leads to the increased risk of rupture. And that's pretty characteristic of VEDS. The importance of genetic testing. So why are we even sharing all of this with you? Because there's an overall importance of genetic testing that I think you're getting now that doesn't have to be specific to just one test, which is why when you go in for genetic testing, you are tested 38 aortopathies. You don't get to go in and say, hey, can you test me for VEDS? When you go in, you are going to be tested across a panel of multiple different genes, including these. When you do genetic testing and VEDS is included, it's going to allow for the identification of mutations in that COL3A1 gene, which will help confirm the diagnosis. In individuals with a family history or suspected symptoms of this condition, so early diagnosis through genetic testing, it can be life-saving, allowing affected individuals to take the necessary precautions to prevent severe complications. That said, even in those that know they have the condition already, risks of complications are high, and life expectancy, unfortunately, is significantly shortened. So when you are living with VEDS, there is comprehensive management strategies on basically just how to live your life, right, with VEDS. Individuals with VEDS are told to avoid activities that can result in injury. Obviously, as we've described, what can happen to organs, right? Regular monitoring for arterial rupture, it's crucial. And maintaining good dental hygiene can help prevent gum damage. Medical treatments, blood pressure control with all of us, right? Can help reduce stress on the arteries, potentially lowering the risk for arterial ruptures. Surgery might be needed in case of ruptures, although it comes with risks in and of itself due to fragility of tissue. Surgical interventions are considered high risk in individuals with VEDS due to the fragility of the tissues, as we just mentioned. However, these interventions might be necessary in an emergency, such as an arterial or organ rupture. And so we often will talk in this community, can you have CPR if you've had a dissection or you have an aneurysm? And the answer is yes. You should receive CPR unless you personally have a choice for DNR. Why? Because there's a cost benefit. You could probably be saved. Your life could be saved from having CPR performed. You can't worry about the pressure that's being exerted on a rib cage that is meant to protect the heart from severe damage, right? You're just helping a heart pump. It's like if you're choking on something, but you know you have an abdominal aneurysm, of course you want that person to receive like the Heimlich. You want that choking to stop so they can breathe. You can't worry about what if I burst an aneurysm. No. So here, if you're had an organ rupture or you have a major arterial rupture, of course you're going to have surgery. And you just need a skilled surgeon who understands VEDS so that they know how to properly be prepared for any emergencies that happen during the surgery. There are going to be suggested lifestyle modifications, and that's going to be engaging in regular but low impact exercises that can actually help maintain strength, and it can help you with stability without putting any undue stress on the body. Activities such as swimming or walking, those are, you can't really hurt yourself swimming, right? You're not going to have any massive impact. So that's what's going to probably be suggested to you. I'm sitting here stressed just listening and learning about this again. So we know there's going to be a high degree of emotional and psychological support needed in people that have VEDS. It's going to take a toll on not only themselves, but their families. And so counseling and psychological support can really be beneficial in coping with the psychological impacts of living with VEDS. Support groups can also provide a safe space for sharing your experience and getting some advice. And understanding and managing VEDS, we can really arm ourselves with knowledge, equip ourselves with strategies, and foster a supportive community for all individuals and families that are affected by this disease. So let's review this briefly, okay, because it's a lot of information. A lot of big words are about to happen, and I think, laugh with me, folks. Laugh with me because I don't know how to say these words. So there's several other different types of EDS, of course, EDS, all with their own unique characteristics. Here we go. Mm. 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 Dermatosparaxis. Dermatosparaxis. Characterized by extremely fragile skin that bruises easily. Some kyphoscoliotic. Oh, I cannot say this word. Kyphoscoliotic. Sounds good to me. Sound good to you? No idea. You put a K in front of something, I don't know how to say it. But that one involves severe muscle weakness and the curvature of the spine. Mm. Arthropalagia? Good, sounds good to me. Characterized by severe joint hypermobility and recurrent dislocations. No offense to people that have these. I don't know. I didn't practice. Myopathic EDS. Whew. Marked by muscle weakness, especially in the shoulder and the hips. There is periodontal EDS. Who would have thought? And that's severe gum disease and other dental problems. Spondylodysplastic. Oh, that sounds good. That was fun to say. That involves short stature and skeletal abnormalities. Okay. Musculocontractural EDS. Oh, that was good too. Characterized by congenital contractures of the fingers and toes and distinctive craniofacial features. In conclusion, you guys, understanding Ehlers-Danlos syndrome and its various subtypes is vital for proper diagnosis and management of aortic disease. So by raising awareness, which we're doing here, and hopefully when you share this, we'll raise awareness in the general population, and just staying informed, we can actually empower ourselves to, and our loved ones, of course, to make the best decisions for our health. And as we continue to explore various genetic conditions related to aortic disease, don't forget to keep an eye out for our next article on non-syndromic hereditary thoracic aortic disease. Gosh, this has only been the syndromic. I can't imagine what big words are in the non-syndromic. Again, if you have any questions or concerns, you can email us at info@aortichope.org or Ryan Rodimer directly at ryan@myaorticjourney.com. This is a lot, guys. It's a lot of genetic information, but good stuff, right?
Ryan does excellent work.
It does. Mouthful. Mm, mm. Okay, moving on. Feel Good Friday. It was the unofficial start of summer a couple days ago. It was Memorial Day weekend, giving everybody the feel good vibes, right? We were driving around looking to see if we could see anyone that was grilling because I didn't see a lot of people grilling. Um, and that bums me out. I like to smell the grilled hamburgers and I love a hot dog this time of year. Shh, don't tell my doctor. So it was the long weekend, which meant it was time to fire up the grill, gather with friends and family, and kind of enjoy the flavors of Memorial Day weekend. So juicy burgers, hot dogs. I didn't even think about a rib, grilled corn, everything in between. Nothing brings people together quite like a good old fashioned cookout. We were asking everybody to share their favorite cookout foods. Look, I love a hot dog, but I don't love a grilled hot dog. I love an old fashioned boiled hot dog that you get from a street vendor off the streets of New York City. I don't want to know if it's been infiltrated by rats because I don't care. You put that hot dog that's been in the boiling water in the bun, which is always soft, and you slop some sauerkraut on it, and then I eat it. And it makes me very happy. But I do like grilled burgers.
I
That
don't.
I will. I will like a grilled burger.
I don't eat hot dogs at all
Well, you're
for any
missing.
reason.
Okay, that's fair. I
I
don't do
like
kielbasa.
burgers.
Mm?
I'm
Mm.
not a cheese guy, so I'm always like,
Yeah,
oh,
me either.
don't put cheese on that burger, please.
I know. I know. And if I do have cheese, I'm a provolone girl, not an American.
Mm.
And try traveling out of the country and being an idiot and saying, like, "Do you have American cheese?" And they're like, "What? I have cheddar." What's American cheese? What that is? Because it's not real cheese.
Uh, not a
Right? They
cheese
have all
guy.
that Gouda. They can have some Gouda. Brie. What is brie? Why did people eat it? I don't know. I'm not a cheese person. Okay, we're moving on, you guys. Look, we had a great teaser from Michael Pace. I don't know if you guys remember, and we talked about him for a while. He did a Spartan race for us not too long ago, and he had an aortic dissection. Interesting story. Had a great teaser. I hope you guys got a chance to see it. It just came on. I'm going to let Josh tell you guys a little bit about it. But then what you need to do is go on our website, click the word programs, which is right there in that upper left-hand corner. A drop-down box will come. Go right to the AHTV Survivor Series, and you'll be able to check it out. He should be right at the top. But tell us a little bit more about that, Josh.
Yeah, you don't even have to click. You just have to hover over programs.
Mm, there you go. Just hover.
So Michael, he dissected at 35 years old. And he starts his explanation
Yeah.
a couple of days before he goes into the emergency surgery on Thanksgiving Day. And he's doing a light workout. He's got a small bubble in his chest. And he's like, well, I'm going to let this sit. You know, it was uncomfortable, but he went through the festivities.
Yeah.
He's the kind of person that doesn't have any primary care, 35, runs through obstacle courses, feels strong and
Right.
healthy. And so a couple days later, he walks into a walk-in clinic. He gets diagnosed with indigestion. But the following day, that kind of bubble went away. Right? So he was like, all right, I'm fine. A couple days later, he's out walking with the family. Anxiety starts to pick up. His hands get sweaty. He's starting to get angry for no reason. He gets back to the house and he's sitting on the counter, and 5 minutes later, pain strikes his chest and he's off to the ER. So he calls his friend Sean, and Sean gives him a ride, at which point he is at the emergency room screaming at the top of his lungs. He's ripping, his face mask off because this is happening during COVID. And they're like, sir, you have to put your mask on. And he's like, it feels like I'm dying and nothing's being done. So it turns out that he has a neighbor, and his neighbor is a cop. His name is Heath. He calls Heath and says, I need help. Heath shows up, walks right through the hospital, goes up to the head doctor in the emergency room and explains what's going on with Michael. At which point that doctor is flummoxed, like, why isn't that person already back here? And he gets fast-tracked to CT scans, and they discover the dissection. Chaos is everywhere.
Mm-hmm.
And so at one point, he's just like, all right, just tell me what's going on. You guys are being very evasive. And they were like, emergency surgery. They explain what's going to happen here next.
Mm-hmm.
And it turns out that where they sent him to get his operation, the thoracic surgeon is just nerdy about the aorta. Like it's a
Mm-hmm.
thing that he pays attention to. He
Yeah.
just stays on top of these. So while he's getting his anesthesia, the anesthesiologist is like, listen, you're going to be fine. Everything's going to be okay. And what's
Mm-hmm.
interesting about this point of the story is we never hear the anesthesiologist be brought up in these stories except for, I'm getting my 5, 4,
Yeah.
3, we don't see anything. But
Right.
he's
Right.
over here just telling him, you're going to be fine. I'm going to talk to you in a couple of days. Don't worry
Mm-hmm.
about it. You're in good hands. So he goes under with kind of that hopeful energy going into it. So that's kind of
Mm-hmm.
nice. He's
Yeah.
in and out of comas. He wakes up. He remembers at one point his neck was all creaked up and he couldn't talk because he
Mm-hmm.
had intubated or what have you. But he gets writing equipment, solves that, and a couple days later he comes out. And then that anesthesiologist walks back in. He's like, I told you were going to be all right. And he was like, that was so profound.
Mm-hmm.
So then he goes through the limitations. And once again, we're in a situation where at 35 years old, there's no data. There's no
Not a
data.
lot. Yeah.
So he's walking immediately, like he's walking as much as he can regularly.
Yeah.
And if you'll recall, Amber Williams
Mm-hmm.
with Turner syndrome, I believe, like she was
Right.
also in her mid-30s when she had her first dissection.
Yeah.
And she got up and she started walking again as well. And so there is something to be
Mm-hmm.
said for age and healing factors.
Yes.
So if you're in your
Younger.
50s and 60s, don't expect these same results.
Right.
Um,
No.
so he took
But
two.
conversely, it's like a curve. The younger you are, the faster you heal. Then there's that mid range where we're like just not it's not going to happen and we're uncomfortable. And then the older you are, the less the nerves hurt when they reconnect, which is why a
Interesting.
lot of times if somebody has this surgery and they're 70 some years old, it's black or white. They either are bouncing back or they're not, and they may not.
Mm.
So it's very strange, right? So continue.
Okay. He right away he had genetic tests. Everything came back
Mm-hmm.
negative.
Mm-hmm.
He only took 2 months off of work, but that was driving
Mm-hmm.
him insane.
Yeah.
He's got 2 children, so he spent time with them with a Marvel marathon.
Mm-hmm.
He's
Mm-hmm.
like, toward the end, they were like, "Can we watch anything else?"
Yeah.
Let me see here. We talked about him going back. He's like, "I went back to full force lifting," and I was like, "What does that mean?" Mostly it's later weights and a lot of
Mm-hmm.
reps. He's at a 45-pound weight restriction right now.
Right. Many reps.
Um, during one of his annual scans, I think
Mm-hmm.
so. He does a CT scan and an echo, and he's doing
Mm-hmm.
these in 6 months intervals. So, like, they're on a year cycle, but they have a 6 month overlap. So every six
Mm-hmm.
months, one of these two is happening,
Right. Same
and
with me.
they see a descending
Mm-hmm.
dissection, right? And so when he goes
Mm-hmm.
back to find out more information about this, he gets to explain to him that it's in the notes that they did see it and they've been medically
Mm-hmm.
managing it, and that's kind of the protocol,
Right.
which we now know that started back in the 50s and 60s when they were like, don't try to repair the whole thing, repair the most
Mm-hmm.
dangerous
Critical.
thing, and then let him get back together.
Mm-hmm.
So he's he's pushing back to normalcy as much as he can.
Yeah.
He was getting into the Spartan races right before all of this happened, and he wanted to see
Mm-hmm.
if he could get that kind of thing going. And
Yeah.
so, that's where he found us, and he knew that he was
Yeah.
going to give us a little bit of love with that. So he
Mm-hmm.
achieved his first 5K
Mm-hmm.
uh, a year and a half to 2 years ago, and he also learned how to run the event itself. So now he's gonna
Mm-hmm.
see if he can start putting together more and more of these, which I think is great.
I love it.
He
Yeah.
has since upped 5K to 10K, and he's looking to
Mm-hmm.
grow bigger awareness.
Mm-hmm.
He raised 1,500 and organized the race with 18 people that participated.
Mm-hmm.
So
Yeah. You did a great job.
yeah. After surgery,
Yeah.
it might seem scary because you're going to go through that night again and again. And
Mm-hmm.
he just wants to remind everyone out there, just take care of yourself, right?
Yes.
And he was a glowing example of self-advocacy,
Yeah.
right? I mean, it's hard for, I guess, in your early 30s, mid 30s, to even conceive that this is a possibility.
Mm-hmm.
And you're going to get missed. That's the real problem, right? Like
100%.
they didn't do any, I have chest pain. Oh, you have indigestion, and that seems like a shocking diagnosis.
Yeah. Yeah.
Um and so,
They
sure,
probably didn't even run a EKG to see if he was having a heart attack.
hard to say, right? Hard to say.
Yeah.
But like, we hear these stories of people being brushed off,
Mm-hmm.
and that's
Right.
really the trouble. That's
It's
really the
terrible.
trouble. And
Yeah.
so there is, in his family, there is no early deaths, early heart
Mm-hmm.
attacks, anything
Right.
like that. So he
Right.
is legitimately patient X.
Yeah.
Yeah.
Yeah. Scary, but doing such good stuff and bringing awareness. I mean, just all the people at his job, and then being able to show the video and talk about what he did. My goal is, if we are lucky recipients again next year, I would like to be able to be there and capture some of this on film. We're given a notification a little too late, but I think we would be okay doing it in the future. I think we would be good.
Right on.
So good, good Saturday story.
Excellent story. He's a good
Yeah.
storyteller. Yeah.
Yeah. Yeah. All right. We are moving on with Sunday, asking you guys to share with us some of your resources. This was our reading resource that we have. We have a reading resource. If you click on the resource button, are there any books you guys have read about aortic disease or aneurysms or dissections in the community that we are missing here on our list? Because we would love to know it. We would love to know about them. We'd love to know what you loved about them. And so while you're at it, telling us and read some of these other books that we have on this reading list. I think I might be able to click on this real quick. Yeah. Um, First and foremost, what you're going to find on this list is our book, Aortic Dissection: The Patient Guide. That's the first one we have, and you still have an opportunity to download that for free, and to order it in bulk using a form. But here's some of the books that we have. I'm going to do a very quick overview because we've done this a few times and it's all right here for you. A community member and our moderator for our Spanish support group meetings, because she became a therapist later in life, Maria T. Herrera wrote a book called Dissected: Healing with Poetry, My Journey with Two Dissections. So she had not only one, she had two, and she wrote all about it. And I love her cover photo. I love it so much. This all happened in 2009. And she says that the fears and the questions became very overwhelming. And the difficulty with the diagnosis and the lack of knowledge of some of the medical professionals really was working against her, to what we were just talking about, being, I guess, profiled and weeded out and just kind of ignored. And what could have been addressed initially in her situation with a stent or an observation, if found on time, it actually led to a complicated and dangerous surgery, which was her open heart surgery. And that just kind of seemed to forever change her life. And the psychological traumas after surgery became a daunting chore, which led her to this healing path of writing poetry. So if you like poetry, or even if you think you don't, you need to read this because it will resonate with you. Push pause for just a second. Okay. All right, ready to go. All right, our next book that we have is written by Andrea Garrett Helms, or A.G. Helms, and she wrote a book called Everyday Sinner: Undeserved Miracles from an Unconditional God. There's a very big explanation here, so let's talk about this a little bit. I laid there helplessly looking at my beautiful husband's sobbing face, and as the surgeon said, you need to decide who is your priority, your wife or your child. Life is such an amazing, wonderful journey, but at times it's like a badly paved road, and you're traveling along and bam, hello whiplash, hello insurance claim, hello Route 44 half and half, tea with lemon, and the good ice, which I know what that is, you've waited for all day, has been dumped all over the floor. Our lives, their lives over the past 2 years has been more like a bumpy jungle safari ride in a Jeep, in an old Jeep with 3 partially deflated tires. I love that description. God and we beat infertility. God saved our baby, and God saved me, a walking, talking, breathing hot mess. He had mercy on an everyday sinner like me. There's 4 cases in the world of pregnant women with type A and type B aortic dissections with an aortic aneurysm. I think that stat has probably changed since she originally thought about writing this book. 2 of those 4 resulted in both the mother and child perishing. People say that they're walking miracles, but We say our God is a God of miracles. It took me 2 years to write this book, emotionally and physically. It holds the most personal details of our journey. I pray that it gives you hope. I pray that it encourages you to speak to your mountain, whatever it may be, with boldness and confidence. And I pray that it brings you closest to Jesus Christ. I pray that you turn the last page feeling loved because your friend, you are so very, very loved. And it's interesting. I hate correcting people and information that they put in their books because this is their journey. However, um, I'm going to guess that her hospital system, that was their stat for that system because there's a huge pregnancy community that exists. So I would really be interested in rereading this book and really learning more about what her experience was with her exact hospital system. Because the reality is most hospitals see one person maybe a year with a dissection, let alone somebody who's pregnant. I mean, you're talking about needle in a haystack situation here. All right, our next book is by Terry Benson. It's called How My Ordinary Became Extraordinary. It invites you inside Terry's harrowing journey through one of the worst possible heart conditions. After waking up to find her life fractured by her condition, she fought to reassemble the pieces into a normal life. But when climbing the stairs felt like climbing Everest and brushing her teeth became an actual accomplishment, it didn't take long to feel discouraged. This is the true story of her recovery from an aortic dissection and the people and mindsets that pulled her through it. Whether you're standing atop your personal mountain or still scaling the cliffs, this book is for you. All right, the next book we have in our shelves is by Robert C. Fisher, Life After Death, a true story of surviving an aortic aneurysm and dissection. Imagine rising on a normal day unaware that you have a rare, deadly underlying medical condition. Without warning, an excruciating pain crosses your chest. You barely make it to the living room, from your living room to the operating room, but your body somehow manages to hang on, narrowly surviving what most do not. But surviving the initial incident is only the beginning as complications arise. This is the true story of Robert, who at age 55 experienced one of the most traumatic events in his life, an aortic aneurysm and dissection. With less than a 5% chance of survival, Robert was one of the lucky ones. You may remember hearing about aortic dissections. It was what killed TV sitcom actor John Ritter in 2003 at the age of 54. Trying to make sense of his near death incident, Robert spent many hours talking through what had happened to him with his wife, Carol. Those talks soon turned into journaling, all about what he had to cope with. That journaling evolved into writing this book as Robert wishes to bring awareness about this deadly condition for those dealing with an aortic dissection or for those interested in what life might look like after such a terrifying ordeal. This book may offer you some insight. Okay, then we have Miracle Man, Beating the Odds, Cheating Death by Scott Pribble. And do you know anyone facing or has faced major surgery, illness, disease, or other life-changing personal financial situation? And does that person need hope or inspiration, spiritual grace, and the sheer will to keep going? Do you know people who need to lose weight quickly yet permanently with minimal exercise? And the author, Scott Pribble, survived an internal injury that is 90 to 95% fatal. In this book, he actually describes his 7-year rehabilitation and comeback. Pribble also describes how he lost 50 pounds in 2 months. I want to read to you one other book that I believe was missed in this. It may have come up later, so that's why I'm pulling it up right here. And that was a book, 2 books actually. One called The Last Breath and the First Beat by Danielle Rambelli. Danielle, and he says, my name is Danielle, and like many of you, I survived a life-changing aortic dissection. It was an experience that shook me to the core, not only physically, but emotionally and mentally as well. He says, I'm an operations manager and engineer, a proud father of 3, and my life took a sharp turn when I faced the terrifying reality of an aortic dissection. Through a long and difficult recovery process, I found strength, resilience, and an entirely new perspective on life. I realized that my journey wasn't just about surviving, it was about transforming. I've turned my experience into a message of hope and healing, and I've written a book to share what I've learned with others who are facing or have faced this battle. My book, The Last Breath and the First Beat, is more than just my story. It's a resource for anyone who has gone through the life-altering experience of an aortic dissection. In the book, I open up about the challenges I faced from the initial shock of diagnosis to the long road of recovery, including how I learned to manage PTSD and the emotional scars that followed. My goal in writing this was simple: to help others like you find light in the darkness of times and discover a new path forward. If you're looking for a companion in this journey or just need a reminder that you're not alone, I encourage you to check out my book. We are all survivors, and together we can support one another through the highs and the lows of recovery. And the last book that we have on here, see, our list has grown, which is awesome, comes from Michelle Wegman, called My Heart, My Life, My Story of Surviving Aortic Dissection, Open Heart Surgeries, and Aneurysms. She says, "This is my story of survival and beating the odds after suffering a massive aortic dissection that required an emergency open heart surgery to save my life and all the complications and other surgeries that ensued." That already sounds like a catcher right there, right? Because lots of other things happen. The book is meant to be inspirational while learning to navigate life in the aftermath of aortic disease and aneurysms. Furthermore, this book is written for the love of golf. Right? Comes out of nowhere. For the love of golf, and more specifically to demonstrate how golf mimics our daily life. It's also the best way I know to pay homage and express my gratitude to my incredible medical team keeping me alive today. What I love about this book, gosh, every book is different. Every book is very different. We knew that, but this book, she really creates a lot of support and resources listed in this book, things that are tried and true by her within the community. So it's a very different perspective. And I think you're really going to enjoy her different take on sharing her story of survival. So check out resources. We're going to be adding a new book, and we're going to be adding it very soon. And it's called Aortic Disease, the Patient Guide. And it's our second book in our bookshelf of books. This one takes you through aneurysms, valve disease, aortic valve disease issues, and a little bit of talk about dissections. But primarily, it's taking a step back. And let's talk about the different disease elements that can happen before a dissection and how you would diagnose, how you would treat, what life looks like, emotional, physical, sex, diet, uh, um, what is it called? Exercise. That's the word I want to say. And it talks about the genetics and the medications. I mean, it's all encompassing like our aortic dissection patient guide, but we're going back in time because we want to try to stop those dissections. We're kind of thinking aorta, thinking family in this book. So that was our share with us Sunday. So I hope to read some of the books that you guys are reading that pertains to aortic disease. It's a mouthful. All right, we're moving on to events so we can wrap this up. I have not updated anything, you guys. No, have not. Still pulling the June calendar together. I did find out that we're going to have a cooking demonstration. I think I want to say it was about cheese. Yeah, that's coming up the first week of June. So we're going to do stuff with cheese. So I have a lot of things coming up for June, but still coming up for the rest of this week is our Ask a Doctor, which is tonight. So what is Ask a Doctor? Well, typically it's with Prakash, but in Dr. Prakash, but instead it's Dr. Tyler Wallen. And what happens is at 6:30 p.m. tonight, Dr. Wallen's going to go on Facebook using his wife's account. I just found out because he doesn't have one. But needless to say, that's who is going to be answering it. You're going to put questions up on this Facebook post with Dr. Wallen's face right there. You're going to put your questions in the comment section, and he is going to answer them beginning at 6:30. Simultaneously, Terry Cook and I will be on YouTube reading those questions and providing you the answers. In addition, you have an opportunity to post your questions in chat on YouTube, where we're going to share them on Facebook to get his answer and then share them with you on YouTube. It's kind of like a simulcast. If you want to ask anonymously because you don't want everybody to know who you are and you're asking those questions, there are links to a form where you can post that question anonymously. So there's a lot going on, but it's going to be a lot of fun. All right. Then we have a support group meeting. Our general support group meeting, last one of the month, happens on Wednesday at 7 p.m. And then we have Therapeutic Thursday with John Quick this Thursday with Mark Martucci. He spearheads our support group meetings that happen on Wednesday at 10 p.m. I think it's Wednesday. I'm pretty sure it's Wednesday. Could be Tuesday. I can't remember. But he spearheads that. He's out in California. That's a significant time zone difference between California and like Spain or Portugal. I can't remember where John is now. So that's happening. Excited to have that happen at noon on Thursday this week. And then the month, it's done and we get to start June. So yeah, that's going to be coming up for all of you. You'll have a chance to see the June schedule soon. And I think that's all I have for today. That's all I have. What's going on behind me that you can't see is things in my house. I got a lot of things happening in the house that need to be repaired. So thanks for bearing with me and having this be recorded. Sorry I missed you guys live, but I will see you again real soon every Monday, 3 p.m. We do this week in review. So please click like, please click share, subscribe, the bell. Definitely share this with people because somebody else is going to learn some information. It's going to be really helpful. We appreciate you. Thank you again so much and have a great rest of your week. And while not all forms of VDS carry risks for aortic complications, one subtype, I just read that. I just read that. Sorry, I screwed up. Where should I pick back up? I think I said fragile skin. And its distinctions from other types of VDS can be a literal lifesaver. Okay. Okay. See, I don't want to get the giggles. Shit's what happens when I'm doing not live. Sorry, do you hear all the phone going off? Okay, good. It's every time anybody walks by the cameras. Okay.